Hello again. Okay, so now we are on chapter 51, which is elimination. I am going to break this whole PowerPoint into two video lectures. The first half will be bowel elimination. The second will be urinary. So here comes bowel. Get ready, get set, let's go. All right, so bowel elimination. We have to poop to maintain homeostasis, right? We have to get rid of liquid and solid waste products. And remember, any changes in what is the typical bowel or bladder habit can signal some kind of disease, even cancer. So it's important as a nurse to ask questions about elimination. So lots of things can alter bowel function. IVs, surgeries, immobility, medications, different diets, right? And diseases can sometimes cause us to create a bowel diversion, in other words, an ostomy. Stool specimens. We collect stool specimens for screening for diagnostic tests. Sometimes we're looking for occult blood. What does that mean? So the word occult means secretive or hidden blood. So you don't want to be so worried about seeing frank red blood in stool. Usually that's a hemorrhoid. But when you have black tarry stools, often that is a sign of a lower GI bleed. So we can do a stool specimen and check to see if there's hidden blood. We can also look for bacteria and we can look for parasites. You heard me, parasites, things like worms. And when people have things like constipation, which means very hard, infrequent stools, or diarrhea, which is lots and lots of loose or liquid stools, that usually is some kind of a problem that could relate to something that's more pronounced, or it could be something simple. So let's talk about what these things could be. First of all, I shouldn't have to say it, but I'll say it anyway. Always use standard precautions. Use your gloves when you think you're going to come in contact with any bodily fluids, and make sure you wash your hands, right? What are the different things that affect bowel elimination? Your diet is a big one. Do you eat enough fiber? 25 to 38 grams a day. Do you drink enough water? Water. You know, an adult needs about 2,000 to 3,500 milliliters of water a day. That's about 6 or 7 of these. Activity level. When you move around, it stimulates peristalsis, right? And increases muscle tone that you need in order to poop. How do you poop? Squatty potty. Squatting is the best position. It helps, lets gravity help. Psychosocial factors can affect people's bowel movements too. Things like depression can cause constipation. Anxiety, nerves can cause diarrhea. If somebody's in pain, right, limits their ability to push. Or if they have pain because of something like hemorrhoids, it's going to make them not want to go to the bathroom. Pregnancy, pressure because of the growing fetus slows peristalsis down. And personal habits sometimes play a part. I don't like to do number 2 in a public toilet, you know, but if I have to, I will. A lot of people, older folks mostly, believe that you have to move your bowels once a day. That's not necessarily true, and we'll talk more about that. When you're up and about and moving and you're eating a full diet, yeah, you're probably going to go every day. When you get older, not eating as much, not moving as much, you know, sometimes you don't need to go every day. Every other day is sufficient. But some people have a hard time understanding that. And then when you're in the hospital, everybody and their mother can see your butt, right? So you want privacy. You're not going to get it. And sometimes that can really impact your ability to move your bowels. Medications. What kind of medications can we take? So there are laxatives and there are stool softeners. A laxative actually makes you go. It stimulates peristalsis. A stool softener does what it says. It just softens your stool. The stool softener you need to know, docusate sodium. Brand name is Colace. Safest drug out there, right? It's a stool softener. It's not a laxative. You don't get dependent on it the way you can with chronic use of laxatives. It just keeps your stool soft. It draws more water into the large bowel so that your stool is softer. So, and laxatives, here are the 3 I want you to know. Polyethylene glycol 3350, also known as Miralax. Milk of magnesia and magnesium citrate. These are meds that you definitely need to know. I'm actually going to add one more here. I'm going to add lactulose because that's one you need to know. And lactulose is not just a laxative, it's an osmotic laxative. But we'll talk more about that when we get to med-surg. But here, these are the laxatives, and this is the stool softener. See this big stars down here? Note. Laxative overuse. Somebody who chronically uses laxatives and can't go without using them, it's a problem because if they ever stop, they're not going to be able to move their bowels, right? And it's going to result in chronic constipation. Nobody should be using laxatives on the regular. Incontinence. That can happen for a lot of reasons. That means that's the inability to control the defecation. Usually diarrhea can do it, but medications can do it. Infections can do it. If someone has a fecal impaction, they'll have loose liquid stool and sometimes can't hold it. If they are incontinent because of, a cognitive disease like Alzheimer's or one form of dementia, provide perineal care as quickly as possible and use a moisture barrier so their skin doesn't break down. Okay. Flatulence. It's gas. That's the bowel gets distended because of gas, and it can make you cramp or feel full. And if your abdomen is distended, make sure that you are able to pass gas. Oftentimes, we won't even let you out of the hospital until you pass gas to make sure that everything down there is moving. Get the patient to move. Ambulation really promotes the passage of flatus. Hemorrhoids, they are no fun. Hemorrhoids are engorged, dilated blood vessels, varicose veins, basically, in the rectal wall. And people get them for lots of reasons. They have a difficult time defecating because they're always constipated and they strain and they strain. That can do it. Pregnancy, all the pressure, liver disease, heart failure, and even guys that do jobs like heavy lifting, like guys that move furniture, stuff like that, can also do it. They're itchy, they're painful, and they can even bleed. Okay. The patient should use moist wipes, not dry toilet paper to cleanse it. There are different ointments, topicals that you can use. And then there's something called a sitz bath. For those of you that had vaginal deliveries, you may be familiar with this handy dandy little thing. It sits on top of your toilet and it's got a tube that connects to water. So water will flow out through these holes and kind of just wash over your perineal area. Really does help. Should be cool water, not cold, cool. Or you can even put an ice pack on the hemorrhoids to help shrink them. Ostomies. There's a lot to say about ostomies. So sometimes people have issues in their bowel that prevents the elimination of stool the way it normally should be eliminated. Bowel diversions are ostomies that can be temporary or permanent, and it's an opening that we create surgically that allows part of the intestine to kind of stick out and fecal matter or stool to come out that way. Ostomies are either in the large intestine or the small intestine. Colostomies are in the colon. Ileostomies are in the ileum, right? So colon, large intestine, ileostomy, small intestine, okay? It's important for you to know an ileostomy is going to produce effluent that is liquid and odorless, usually like a greenish color, just pure liquid because it's high up in the digestive tract, right? Colostomies, depending on where in the large intestine they are, can produce rather either pasty stool, semi-formed stool, or actual formed stool, just as if somebody was having a bowel movement the regular way. When you see people with an ostomy, it's usually either colorectal cancer, could be Crohn's disease, ulcerative colitis, lots of reasons, right? A loop colostomy is something that is for a medical emergency and it's a completely temporary thing. A loop of the bowel gets supported on the abdomen with a stoma and it drains. We usually do it in the transverse colon. Don't worry so much about that. We're going to really fixate on colostomies and ileostomies. And don't even worry about double-barreled colostomy. So there are two abdominal stomas, okay? If a patient has a colostomy that is temporary, at some point, usually 6 months or so later, they can do what's called an anastomosis to reconnect the two ends. So let's take a look here. Colostomy can be in the ascending, transverse, or descending colon, or the sigmoid colon. And again, depending on the location, tells you what's coming out of it, right? If it's over here or over here, it's going to be pasty. Semi-formed, even more semi-formed or formed, definitely formed. If it's coming from the ileum, it's going to be liquid. And the further along it goes, the more it smells. All right, important to know. So let's say they had colon cancer here, right? And we had to remove a portion of the colon. We do that colostomy here, and then the parts that we cut out 6 months later, we can reconnect so that they don't have an ostomy anymore if it's temporary. So we have colostomies, we have ileostomies, and we have urostomies, which I'm not going to talk about urostomies till we get to urinary. All right. So let's just stick with colostomies and ileostomies. And if you see here, the appliance or the wafer, that's the thing that sticks onto the patient around the stoma. It's got a little collection pouch on it that the fecal material can go into. You see how it goes on. You have to make sure the peristomal skin, that's the skin, the area around the stoma, is nice, clean, dry, and intact. And the pouch, or the wafer rather, has to fit right around the stoma with about 1/8 of an inch gap. That's it. Not too much of a gap, just a little bit of a gap around it. And that sticks on there, and then the bag or the pouch attaches to that appliance. Okay. And only nurses can change the appliance. I've listed here how to change the appliance, and we're going to go through this in lab. Okay. Disorders of the bowel. Paralytic ileus. You've heard me say this before as a result of opioids. It's basically an intestinal obstruction because part of the bowel kind of seizes, right? It just freezes and there's no peristalsis. Lots of different reasons other than opioids can be different medications, electrolyte imbalances, but most often after surgery. Most common reason is after surgery. And you would identify it by listening to bowel sounds and not hearing anything. Okay, that's an emergency. All right, what's constipation? What's diarrhea? So constipation is a pattern of really infrequent and very hard, very dry stool. Why do people get constipated? Frequent use of laxatives. Older folks, not drinking enough fluid, not taking in enough fiber, not moving around enough. So immobilization because of injury is one thing. Sedentary lifestyle can be changed. Pregnancy can cause constipation, and different medications can cause constipation. Okay. Then diarrhea, that's where you have liquid or loose stools, a lot of them. What causes diarrhea? Viral gastroenteritis or bacterial gastroenteritis, stomach bug. Antibiotics. Antibiotics are the #1 medication that's responsible for causing diarrhea. Inflammatory bowel disease and irritable bowel syndrome can cause bouts of diarrhea and constipation, actually. Okay. Diagnostics. Stool for occult blood or fecal occult blood test, guaiacking of the stool. This is where we're looking for hidden blood in the stool. You must always let the patient know that they should stay away from red meat, citrus fruit, and raw vegetables for at least 2 days before the test because they can cause a false positive, especially red meat. So what you do is you give the patient a hat or a bedside commode, and you have them move their bowels in that. A hat is a little plastic thing that fits in the toilet so that the stool doesn't go into the water. And put your gloves on. There's a little wooden applicator where you take a little bit of stool and from the bowel movement and put it on a window of a little test guard. And usually they'll ask you to take a sample from 2 different places on the stool sample. So in other words, if the bowel movement is like a long semiform bowel movement, take 1 sample from one end and 1 sample from a different location. Okay. And then the card gets closed and sent to the laboratory. Then we can do stool specimens for cultures. We're looking for bacteria, parasites, and ova. Ova are eggs of parasites, right? That's one way to definitively diagnose if you have like Giardia or Campylobacter. They're different types of parasites. People call them Montezuma's revenge sometimes. Sometimes if you go to countries like Mexico, South America, different countries in South America, or even in Asia, Cambodia, don't drink the water. Don't drink the water. And don't brush your teeth with the water because often that's what will happen. You will wind up with a parasite. But there's treatment for that, but we need to diagnose it by getting a stool specimen. And then other diagnostics, a colonoscopy. I think everybody's heard of that. We use a scope, right, to actually physically go into the anus, through the rectum and into the colon, and we look at the inside of the colon to see if we see anything that looks cancerous. We can even do a biopsy. We can look for polyps, which are kind of little growths. They're usually benign. Excuse me. A sigmoidoscopy, same type of instrument, a scope, where we're just going into the sigmoid colon and rectum. So that's just like right there at the end. And client prep for this is fun. Usually clear liquids, and there's some type of a bowel prep 1 to 2 nights before. They used to call the stuff that they would give you go lightly, but you go heavily. Okay. You will poop out things you ate in kindergarten. And when you go in the day of the procedure, somebody has to drive you, so you can't drive yourself there or back. You're going to be sedated. Propofol, Michael Jackson's drug of choice. They will knock you out for this. Okay. And it doesn't take very long, usually less than an hour. Nursing care. So when you're taking care of patients, when we're focusing on the bowels, make sure you're looking at their fluid status, their elimination pattern. Record their I&O. If they're having diarrhea, measure it. You heard me, measure it. Check for blood or pus in the stool. And better prevention. Tell them to eat an adequate amount of fiber, drink enough fluid, and get enough movement. Move. They got to move. Okay. And so interventions for constipation, increase fiber and water, right? Give bulk forming products, which are fiber supplements, right? Enemas, last resort, right? We can do them, but we don't want to. And encourage regular exercise. For diarrhea, figure out why maybe. Treat the cause. Sometimes it's just a bug or sometimes it's medication induced. We can give medications to slow peristalsis down like Imodium. And after each bowel movement, apply a moisture barrier to that area after you clean up because, diarrhea can really do a number on your bottom. And when the diarrhea stops, suggest eating yogurt. Yogurt it's got to say live cultures on it, has good bacteria, live bacteria, lactobacillus and acidophilus. And it's probiotic, not the pills now, actually real yogurt. By eating a yogurt a couple times a week, you can actually maintain the balance in your gut of the good bacteria and the bad bacteria because you need them both. Okay. Enemas. So there are different types of enemas. It's where we're taking solution and instilling it into the rectum. And there's different types of solution. Tap water enemas or hypotonic solutions. They stimulate, peristalsis. You don't do them more than once. And then there's a soap suds enema. Yep, soap suds. Pure Castile soap in tap water or saline. And it's an irritant. So when we put it in, it actually makes the bowel start to rumble. It'll make people go. And again, cautious with older folks. Anybody who's pregnant, right? Because there's a risk of electrolyte imbalances and we can even damage the internal mucosa. Normal saline enemas, they're the safest because our whole body's made of normal saline. And it's just the liquid volume stimulates the bowels. And then a low volume hypertonic, don't even worry about that one. Also an oil retention, which is just a lube. Sometimes that's all it takes, right? Because there are complications of being constipated for a while. Fecal impaction. If the stool sits there in the rectum too long, it gets wedged, right? And what can happen is diarrhea can leak around the impacted stool. Enemas or even suppositories or stool softeners can sometimes get it out. But if not, manual disimpaction, put the client in a Sims position on their left side, use a gloved, lubricated finger for digital removal of the stool. Be careful. If somebody's got a cardiac condition, if they've had surgery, if they are not pregnant, if they're pregnant, my goodness, if they have a tendency towards bleeding, or if they're getting radiation therapy, these are all contraindications for disimpacting somebody, really, because the vagus nerve, that's the cranial nerve that goes all the way down to your rectum. If that gets stimulated the wrong way, the patient can wind up bottoming out or vagling down. In other words, blood pressure and heart rate can plummet. They can pass out. And if they have a cardiac issue to begin with, you can really do some damage. So this is a last resort also, disimpaction. And other things that can happen with constipation, people keep straining and straining. Well, they can vagal down. So that can cause bradycardia, hypotension, and syncope, which is fainting. And then, of course, if you're constipated all the time, you can wind up with hemorrhoids or even worse, a rectal fissure. A fissure is a crack in the tissue and it hurts. Bad, bad. And then with diarrhea, there's complications that can occur as well. Dehydration, electrolyte and fluid imbalances, right? And skin breakdown around the bottom because just from the constant stool, and the stool is usually acidic, okay? And that is it for bowel. So part 2 will be coming up shortly, but we're going to close this one up. Thanks for listening. As always, good skill.